So hello everyone, and today we'll be discussing case 12 of the case discussion series, and we have two cases here which are companion cases. So this is the first case where the patient presented with history of headache since 2 months. These are the T1 weighted images, axial section, where we can see that there is some iso-intense lobulated mass lesion in the left CP angle. These are the T2 weighted images, axial section, where we can see that there is hetero-intense signal in the mass lesion in the left CP angle on T2 weighted images. This is the FLAIR images, where we can see that there is mild hydrocephalus with transependymal periventricular edema along with some chronic ischemic changes. This is the T1 post-contrast image, where we can see that there is a broad dural-based lesion which is lobulated in the left CP angle, which shows intense post-contrast enhancement. These are the coronal images which show this particular lesion. These are the Fiesta images, also called CIS images, where we can see that there is no extension of this particular tumor into the internal acoustic meatus, and it's a broad dural based lesion in the left CP angle. So this was the report that I had given, that there's a well-defined lobulated dural based solid mass lesion in the left cerebellopontine angle, which appears iso-intense on T1 and slightly hetero-intense on T2, with multiple punctate areas of blooming on GRE suggesting calcifications. The mass lesion shows vivid, predominantly homogeneous contrast enhancement. There was mild compression of the left hemipons, left middle cerebellar peduncle, and adjacent left cerebellar hemisphere by the mass lesion, which was noted. And the mass lesion also was causing mild effacement of the fourth ventricle, causing upstream dilatation of bilateral lateral ventricles and third ventricles with a mild associated transependymal periventricular edema. There was no evident extension of the mass lesion into the internal acoustic canal, suggesting diagnosis of a meningioma rather than a schwannoma in the left CP angle. There were some ischemic changes in the brain as well. Now, this is the second case, which is a companion case, where this patient came with symptoms of headache, tinnitus, and hearing loss in the left ear since a month. These are the axial T2 weighted images of that patient, where we can see that there is a globular mass lesion extending into the internal acoustic meatus. Ice cream cone sign is seen here very well. These are the T1 axial images. These are the post-contrast images which show intense contrast enhancement in this particular mass lesion along with the ice cream cone sign. These are the Fiesta images, the CIS images, where we can see that the lesion is actually extending into the internal acoustic canal, suggesting a diagnosis of schwannoma more likely than a meningioma. So this was a report that had given that there is a left CP angle solid mass lesion with smooth regular surface, globular in shape and epicentered in the internal acoustic meatus. It shows low signal on T1, high signal on T2 and flare with intense post-contrast vivid homogeneous enhancement. It widens the left internal acoustic canal with intracanalicular component. It exerts a mass effect in the form of indentation of left superior cerebellar peduncle. There was no associated hyperostosis or thickened enhanced dural tail, suggesting a vestibular schwannoma, Kuh's grade 3. So what exactly is Kuh's grading? Kuh's grades have 4 grades. Grade 1 is small intracanalicular component of the schwannoma is only present. In grade 2, there is small tumor with protrusion into the cerebellopontine cistern with no contact with the brainstem. In grade 3, the tumor occupies the CP angle cistern with no brainstem displacement. And in grade 4, the large tumor causes brainstem and cranial nerve displacement.